Let me thank the organizers for inviting me and for the hospitality shown. So my case today is my worst nightmare, which is a PTMC in a pregnant female who developed a hemopericardium. It's a 32-year-old pregnant lady in her 26th week of gestation with a past history of rheumatic fever who presented with NYHA class 3 exertional dyspnea. She had apical mid-diastolic murmur. Her blood pressure was 119/77 with a pulse rate of 107 and it was regular while on maximum tolerated beta blockers. So the routine investigations were done. The ECG showed sinus tachycardia. She had tight mitral stenosis with Wilkins score of 5. She had a dilated LA, bulging interatrial septum to right, and the mitral area was 0.9 centimeters squared. She had grade 1 MR and mild pulmonary hypertension. So my picture on my left shows the mitral valve, ballooning of the anterior mitral leaflet, dilated LA, and the short axis shows a mitral valve area of 0.909 centimeters. So our plan of management was considering the symptom severity and the favorable characteristics of the mitral valve and the tendency of our mitral stenosis to worsen in pregnancy due to increased heart rate and cardiac output to do a planned PTMC at 27 weeks of gestation. Informed consent of both patient and husband was obtained. So this was a challenging PTMC. Number one, it's a pregnant patient, so we need to reduce the risk of radiation to the fetus with minimal fluoroscopic time and reduce frame rate and radiation protection. Valves of pregnant patients are more fragile and liable to complications. And emergency open heart surgery has high fetal and maternal mortality. The transesophageal echocardiography prior to PTMC showed that there were no LA clots. So the usual procedure through the IVC with the 0.35 wire and JR6 French catheter was advanced to innominate vein. JR6 was exchanged to a Mullin sheath. The broken barrow needle was inserted into the Mullin sheath and the IS was punctured when the pressure damped and the LA wire was advanced. So then the mishap happened, one mishap, 2 lives. Fluoroscopy showed LA wire entering the pericardium. Unfortunately, the radiographer hadn't stored it and the patient developed sudden drop of blood pressure and crashed. So what we presumed happened was accidental LA free wall puncture with septal needle. So this is again a parasternal long axis view which shows a mild pericardial effusion, but the 4-chamber view, which I don't have here, showed a big moderate effusion. So we did an emergency pericardiocentesis via subcostal approach and 150 ml of blood was aspirated, auto-transfused with a 5 pigtail introduced into the pericardial space, and we informed our surgical colleagues. So this video shows the pigtail catheter in the pericardial space. After aspiration, the patient was quite stable. So now I was in a dilemma. Should I stop? Should I continue? So there was a little bit of talking amongst us. The points of not to stop is patient has NY3 class 3 to 4 symptoms due to tight MS. There's adverse maternal and fetal risk due to tight MS, as we all know. Hemodynamically, patient was stable after pericardiocentesis. And if we do this again on another day, the patient might get exposed to more radiation. And when we do the PTMC, the drop in LA pressure will reduce the chances of accumulation of pericardial fluid. So what are the points to stop it? Case might be further challenging, we never know. Patient might beat again into the pericardial space. Fluoroscopy type may increase. There might be more radiation for the baby. So the mitral valve was sequentially dilated using a 26 balloon First it was filled to up to 24 cc and then gradually increased to 26 cc. So you can see the inner balloon in the apex. Then we have checked whether it's in the correct position and inflated the distal balloon. So after these challenges, we have a success story with a radiation dose of 44.31 mGi. Fluoroscopy time was 9.19 minutes. Patient was hemodynamically stable. Symptoms were markedly improved after PTMC. Generally, patients with PTMC, even on table when you ask them how they feel, if there is a good valve, they say they feel better. And the post-PTMC 2D echocardiogram, mitral valve area was 1.6 centimeters. Though the ideal would have been around 2, we didn't want to go further. I stopped at 1.6. There was a grade 2 MR and a thin rim of pericardial effusion. The 5-pigtail catheter was kept in the pericardial space for 24 hours and removed as there was no accumulation of pericardial effusion. Patient was transferred to the antenatal unit for further antenatal care on 7th post-operative day. Patient underwent elective LSCS on 38 weeks of gestation. Recently, she visited us with her 3-month-old baby who was clinically and mentally well. So my comments are, the PTMC in a pregnant patient is challenging. Radiation risk to the fetus should be minimized with minimal fluoroscopy time and shielding the abdomen and pelvis, and it should be done by an experienced operator. High chance of perforation necessitating urgent surgery due to the friable mitral valve should be taken into consideration. Emergency surgery carries high risk for both the mother and the baby. Our case was further challenging because it was complicated by a hemopericardium caused by possible left atrial free wall puncture with the septal needle. So in conclusion, this is a challenging case of a PTMCA done in a pregnant female with a hemopericardium, possibly due to accidental LA free wall puncture with septal needle, and we did it successfully with minimal fluoroscopy time and radiation dose. Thank you for your kind attention.